Hello to everybody. My name is Jerina Jaho. I'm an assistant lecturer at University of Vlore, Albania, at Faculty of Health. It's my pleasure to represent my topic to the World Congress on Virology and Infectious Diseases. The topic consists on this title. Patients with HIV and hepatitis B co-infection present special requirements for their management. Morbidity and mortality are significantly higher in patients with HIV/HBV co-infections than with HIV alone. End-stage liver disease, cirrhosis, and hepatocellular carcinoma account for an increasing proportion of deaths amongst HIV-infected individuals. One of the main challenges in the management of both infections is that antiviral treatment must be continued lifelong, as both viruses have long-lived forms that persist on antiviral therapy. Which are some facts about these two infectious diseases? Worldwide, it is estimated that 5 up to 20% of people living with HIV are also chronically infected with HBV. Approximately 10% of this HIV infected population worldwide is infected with hepatitis B. In the US, Western Europe, and Australia, the prevalence of chronic hepatitis B was reported to be 5 up to 14% among HIV positive individuals. Recent data report high global HIV/HBV co-infection rates in several vulnerable groups, like people who inject drugs, men having sex with men, commercial sex workers, and heterosexual adults. So now we can see some data for the hepatitis B virus. Hepatitis B virus is a circular partial dual stranded DNA virus. Is a member of the family Hepatnaviridae, which causes illness ranging from acute self-resolving hepatitis to chronic disease including fulminant hepatitis or chronic hepatitis, cirrhosis of the liver, and hepatocellular carcinoma. Globally, the prevalence of hepatitis B virus infection remains a serious public health issue. Annually, 296 million people are chronically infected by HBV, causing about 820,000 deaths. Human immunodeficiency virus, HIV, belongs to the genus lentivirus family Retroviridae and possesses two types of isolates, HIV-1 and HIV-2. Globally, HIV-1 is the most common cause of AIDS, whereas HIV-2 is prevalent in some parts of Western and Central Africa. The incidence of HBV infection is higher in patients with HIV due to their nearly identical routes of transmission. HIV/HBV co-infection is one of the most significant burdens faced by HIV-positive individuals. Worldwide, there were 37.9 million HIV-positive individuals at the end of 2018. Since both HIV and hepatitis B virus share similar transmission routes, it is not surprising that there is a high frequency of co-infection. Both viruses can be transmitted from mother to baby during childbirth due to the blood exchange from mother to baby, through unsafe medical and injection practices and unscreened blood transfusions. Sexual activity and/or injection drug are other common routes of transmission of the hepatitis B virus among those also infected with HIV. While highly active antiretroviral therapy has dramatically improved the lives of those with HIV, the consequences of associated illnesses such as hepatitis B co-infections have become more relevant. Conditions associated with hepatitis B and C are currently among the leading causes of hospital admission and death in the HIV-infected population. Therefore, the adequate management of hepatitis B and C is now being considered a priority in HIV co-infected patients. For people with HIV, the American Associated for the Study of Liver Disease recommends screening with the following tests, like hepatitis B surface antigen, hepatitis B core antibody, and hepatitis B surface antibody. People with HIV who test positive for HBsAg should undergo further testing with an HBV DNA level to determine the magnitude of HBV replication, as well as testing for hepatitis B-E antigen and hepatitis B-E antibodies. Which are clinical implications among human immunodeficiency virus hepatitis B virus co-infected patients? Infection with HIV compromises innate and adaptive immune responses against HBV, which is reflected in how the disease develops and progresses. HIV may cause liver damage through a number of mechanisms that have not been fully elucidated. HBV-related hepatotoxicity seems to be exacerbated by HIV-induced immunodeficiency. The natural course of HBV-HIV co-infection is more complex than that of HBV monoinfection, and the risk of worsening of the disease is also increased. The risk of chronic hepatitis B progression is five-fold higher with HIV-HBV co-infection, and mortality is twofold higher with HIV-HBV co-infection compared with HBV monoinfection. Studies continue to report that with HIV-HBV co-infections, overall mortality, liver-associated mortality, and hospital utilization rates, and the risk of HCC, hepatocellular carcinoma, are higher than in HBV monoinfected individuals. HIV, HBV co-infected patients face several challenges in terms of therapeutic management, such as antiviral medications are less effective than those prescribed to those with monoinfection. It is a constant concern that viral resistance and subsequent viral failure will arise, and drug with dual activity may simplify the treatment process, but are more challenging to manage when resistance emerges to HIV or HBV. Challenges of co-infected patients with HBV and HIV. Patients with hepatitis B virus and HIV co-infection face several unique and complex challenges due to the interaction between the two viruses and their treatments. These challenges are medical, pharmacological, and social challenges. So, we now are going to improve the surveillance of this co-infection with laboratory infrastructure, with HBV awareness and better study in this co-infection, with prospective cohorts, long-term follow-up, and focus on liver damage or liver disease. Accelerated liver disease progression. HIV worsens HBV outcomes. HIV impairs the immune system, leading to faster progression of HBV-related liver disease, including cirrhosis and hepatocellular carcinoma. Increased HBV replication. HIV co-infection may lead to higher HBV viral loads, worsening liver inflammation and damage. Increased risk of liver-related mortality. Complicated antiviral treatment. Overlapping treatment. Some antiretrovirals like tenofovir, disoproxil fumarate, and lamivudine or emtricitabine treat both HBV and HIV. This is beneficial but also limits treatment options. Risk of HBV reactivation. If antiretrovirals is modified or discontinued, HBV can reactivate, sometimes causing fulminant hepatitis. Development of resistance. HBV can develop resistance to drugs like lamivudine, especially if used as monotherapy. Complex monitoring and follow-up. Monitoring for liver disease, regular screening for fibrosis, cirrhosis, and hepatocellular carcinoma is essential but often neglected. Viral load testing requires monitoring of both HIV and HBV viral loads, increasing the burden of healthcare system and patients too. Drug toxicity and interactions. Hepatotoxicity. Antiretroviral therapy drugs can be liver toxic, exacerbating existing liver disease. Polypharmacy risks. High risk of drug interactions, especially in patients also being treated for opportunistic infections like tuberculosis. Vaccine response and prevention challenges. Pure HBV vaccine response. HIV-infected individuals often have reduced response of HBV in vaccination, delayed or missed vaccination. Missed opportunities to vaccinate early in the course of HIV infection are common. Other challenges are stigma and psychosocial burden, double stigma. Patients may face dual stigma associated with HIV and HBV, affecting mental health and access to care. Disclosure issues. Reluctance to disclosure status due to fear of discrimination can interfere with treatment adherence and partner notification. Research limited setting challenges, limited diagnostics in many regions. HBV testing is not routine in HIV care, leading to misdiagnosis, limited treatment access. Tenofovir-based antiretroviral therapy is not always viable or used optimally. Inadequate clinical guidelines. National policies may lack clear strategies for managing co-infection. What to do step by step during management of HBV and HIV co-infected patients. First of all, initial baseline evaluation, ongoing monitoring schedule, special monitoring situations, and patient education and counseling is very important too. Baseline assessment, use of dual-active antiretroviral therapy, management of drug toxicity and interactions is a very important component of management of these co-infected patients. HIV and HBV viral loads, HBV serologies, liver function test, liver fibrosis assessment, renal function test, screen for other co-infections. Tenofovir disoproxil fumarate or tenofovir alafenamide, lamivudine or emtricitabine, additional HIV active agents as per standard guidelines. Monitor for tenofovir-associated nephrotoxicity, especially patients which are in older age and with other comorbidities. Assess for antiretroviral therapy-related hepatotoxicity. Manage drug-drug interactions carefully, especially with antitubercular therapy and ACV treatment in cases of triple infections. Special monitoring situations. After starting or changing antiretroviral therapy, monitor alanine transaminase and HBV DNA closely for immune reconstitution inflammatory syndrome or HBV flare. Recheck renal function. If antiretroviral therapy is discontinued, avoid stopping tenofovir without a complete regimen change. This may cause HBV reactivation. And also monitor alanine transaminase and HBV DNA weekly or biweekly for signs of liver flare. Monitoring treatment response goals. So, which are target, which is time frame, and which is the final goal. We can have target HIV viral load, HBV DNA, alanine transaminase normalization, HBeAg seroconversion, and HBsAg loss. So we have time frame for each of these response goals. Thank you for your attention.